like we're all set. Let's get started. So Dr. Matthew Lederman is a board-certified reproductive endocrinologist in infertility specialist and is part of RMA in the New York team. And before we introduce him, we wanted to just take a second to tell you guys a little bit more about T.E.A.L for just a moment. We have 3 parts to our mission, which is to provide public awareness and education about ovarian cancer, provide support to survivors, and to fund medical research. Dr. Matthew Lederman recently just joined our scientific advisory board. He's helping us out by doing things like this wonderful webinar tonight. And so the rest of the things that we do just throughout the webinar that even Dr. Lederman's going to be speaking about is if there's any resources or questions that we don't get to tonight, please feel free to reach out to us, and any questions you might have about other resources. You can see we do a lot of awareness and education programs. We also have a lot of support for survivors, families who've been affected and impacted. So if there's anything at all that we can help with, visit our website at tealwalk.org or telleveryamazinglady.org, or contact us afterwards as well. We do have a lot of medical research in our program throughout the United States. We funded at hospitals and institutions across the country. And one of the most important things that you might leave with tonight is just a reminder that there is no accurate screening test for ovarian cancer. All we have are those symptoms and knowing those risk factors. And most of you might know that ovarian cancer is unfortunately diagnosed at a late stage. So knowing the risk factors and symptoms are really critical to this disease. Some of those symptoms are bloating and pelvic pain, frequent urination, and things of that nature. If they go on for more than 2 weeks, you should definitely speak with a doctor. I'm sure Dr. Lederman will talk more about the risk factors a little bit tonight, but we advocate to listen to your body, to know the symptoms, keep your doctor appointments, and make sure you go for those annual screenings, especially with any types of family history. And so without further ado, Dr. Lederman is a board-certified reproductive endocrinologist and fertility specialist and is part of RMA of New York team. After graduating from the University of Michigan, Dr. Lederman received his medical degree from the Chicago Medical School and completed his residency in obstetrics and gynecology, as well as his fellowship in reproductive endocrinology and infertility at the Albert Einstein College of Medicine with the Montefiore Medical Center. Dr. Lederman has published scientific abstracts and articles in peer-reviewed journals in the field of endocrinology and infertility, and it has presented his research at national conferences. He would like to thank Dr. Lederman for moderating with us tonight, and we're now going to turn it over to Dr. Lederman. So everyone's going to see their screen switch for just a moment. Don't get concerned. It's okay. We're just switching to his screen. And Dr. Lederman, can you hear us?
Yes, can you hear me?
Yes, we hear you loud and clear. So welcome, Dr. Lederman, and we have switched your screen, but we want you to go into that play mode, so just make sure you hit play, and we should be able to see it in just a moment. There we go. It's coming up. Give it one moment. There we go. We see disclosures.
Okay.
And perfect. There we are. Okay, so go ahead. Thank you so much.
All right, well, thank you again for that kind introduction. Once again, my name is Dr. Matthew Lederman, and I'm part of the RMA New York team, which is affiliated with Mount Sinai. So tonight we're going to talk about fertility and family planning considerations in those with genetic ovarian cancer risk. So the majority of women with inherited breast and ovarian cancer carry a mutation in either the BRCA1 or BRCA2 gene. With that being said, there are various other hereditary cancer predisposition syndromes associated with different genetic mutations, and one of the other ones that is more common that's out there is the Lynch syndrome. So patients with a BRCA mutation are at increased risk of developing breast and ovarian cancer, as well as other types of cancer, but the risk of developing these cancers at a much earlier age of onset. And because the risk of developing these cancers at a much earlier age of onset, fertility and family planning becomes a major concern for many of these women and couples. And most of what I'm going to be talking about today is mostly BRCA-related, but also some of it also applies to other hereditary cancer predisposition syndromes. So delay in childbearing, combined with improvements in cancer survival rates, have resulted in more and more women having not had children at time of their cancer diagnosis, and therefore having the option of undergoing fertility preservation. So oncofertility is a combination of oncology and reproductive medicine and expands fertility options for cancer survivors. And a significant proportion of these young women who are diagnosed with cancer are given the opportunity to preserve their fertility before undergoing gonotoxic treatment. So gonotoxic treatment refers to cancer treatment such as chemotherapy that can be very harmful to the ovaries and affect ovarian function and what we call the ovarian reserve. So ovarian reserve is a common term we use in the fertility world to refer to one's egg quality and quantity. So as I just mentioned, chemotherapy can be very harmful to the ovaries, and the degree of damage is dependent on a few factors. And probably one of the most important of these factors is the type of chemotherapy. But the dose of the medication also plays a role, as well as the age of the patient. And older patients have less ovarian reserve and therefore at highest risk of experiencing ovarian failure. So patients who have undergone cancer treatment without fertility preservation have been shown to have a substantial decrease in their future fertility. And many studies assessing ovarian function after cancer treatment are often very limited because they don't really tell the entire story. And many of these studies use menses, so one's period, rather than pregnancy as an endpoint. And just because someone has a period after chemotherapy, that does not necessarily mean they'll be able to conceive. So as the acceptance and uses of fertility preservation has increased over time, obviously the safety of those treatments is important. And studies show there appears to be no increase in maternal morbidity and mortality in pregnancies of healthy female cancer survivors who are in remission. And cancer recurrent rates have not been shown to increase after a pregnancy. There's also no difference in the incidence of genetic or chromosomal anomalies in children born to parents with a history of cancer treatment. There's also no increase in childhood malignancies, so cancers in the offspring, with the exception of cancers that arise as a result of inherited cancer syndromes. An IVF with PGD, which is Preimplantation genetic diagnosis, can be performed in these situations, eliminating the presence of the genetic abnormality in the offspring, and we're going to talk about PGD in a little bit. So because women who have a hereditary cancer predisposition syndrome, a gene that predisposes to cancer, because they may develop these cancers at an earlier age, like I mentioned earlier, fertility and family planning becomes a major concern because if they happen to develop cancer, many of the treatments for certain cancers affect the ability to have a future family. So there are various options that one could undergo in terms of risk-reducing kind of surgery, but also there's options in terms of fertility preservation, which we're going to talk about in a little bit. So trying to do these things early on because of the risk of cancer. So women with a BRCA mutation may consider a prophylactic Salpingo oophorectomy. So that is the excision of the fallopian tubes and ovaries in order to decrease the future cancer risk. And guidelines recommend this risk-reducing bilateral Salpingo oophorectomy, often referred to as a BSO, between the ages of 35 to 40, or individualized based on age of onset of ovarian cancer in a family member, and once childbearing is complete. And studies show that a BSO significantly reduces the risk of future ovarian cancer. A newer alternative risk-reducing strategy is a risk-reducing salpingectomy, so first taking out the fallopian tubes, followed by a delayed oophorectomy, so removing the ovaries a few years down the road. And this new concept is based on growing evidence that the fallopian tube is actually the origin of ovarian cancer. However, data on the effects of this ovarian cancer risk reduction are lacking, and therefore this is not current standard of care. And these interventions to reduce cancer risk often elicit fertility and family planning concerns among young BRCA mutation carriers. And children of a BRCA mutation carrier have a 50% chance of inheriting the gene. And any woman who has other cancer predisposition syndromes, the way it's inherited, all offspring have a 50% chance of getting that gene. And women and couples in these situations have the option of doing IVF with preimplantation genetic diagnosis, or PGD, to prevent transmission of the genetic mutation to the offspring. So there are conflicting studies that exist regarding the effect of a BRCA mutation on fertility. And there are multiple studies that suggest that BRCA mutation carriers, more BRCA1 compared to BRCA2, that they may have decreased ovarian reserve, so once again, lower egg quality and quantity, compared to women without a BRCA mutation. And some studies have also implied that BRCA mutation carriers who undergo IVF may not do as well as compared to non-BRCA carriers. However, some studies have failed to demonstrate an association between BRCA status and fertility. And they haven't necessarily looked at, fertility in other cancer predisposition syndromes in terms of, fertility markers, but I think that's probably going to be more down the road. But so what I'm talking about now in terms of, it's more BRCA related to fertility. So AMH, which stands for anti-Müllerian hormone, is a blood test that we use to assess one's ovarian reserve egg quality and quantity. And this is a common test we evaluate for our infertility patients when they come in at a new patient visit. Okay, and this blood test can be done at any time throughout the menstrual cycle. And there was a study published a few years ago that showed that BRCA1 carriers had lower AMH concentrations compared with non-carriers. Interestingly, within the past year, there's another study that showed that AMH concentrations were also low in BRCA2 carriers. And that was actually the first study that showed that in BRCA2 carriers. Most of the studies looking at fertility and ovarian reserve have shown BRCA1 carriers seem to be more potentially affected, not to say BRCA2, and this is one of the first studies that showed it could also exist in BRCA2 carriers. Our team has also looked into this, and we presented an abstract at the annual ASRM conference a few years ago. ASRM stands for American Society of Reproductive Medicine, and it's the annual infertility conference. And we too found a trend towards accelerated age-related decline in ovarian reserve and egg yield in BRCA1 carriers. So BRCA carriers are often faced with difficult issues regarding the desire to conceive. And one factor that may influence their decision is whether or not they plan to undergo a risk-reducing surgery, so risk-reducing BSO, and also when. And women who are considering undergoing this risk-reducing surgery, they have the option of freezing eggs or embryos prior to the risk-reducing surgery, and in the future, they could still carry a pregnancy. Women don't necessarily need ovaries in order to maintain an early pregnancy. We could give them back hormones in the form of estrogen and progesterone to support an early pregnancy. So they have the option of freezing eggs or embryos, taking out the ovaries and the fallopian tubes, and they could still carry a pregnancy. They do not need ovaries. Another factor that may influence a BRCA carrier's decision include the potential risk of diminished ovarian reserve, because as I just mentioned, there are some studies suggesting that these patients may have diminished ovarian reserve. Risk of passing on the mutation to the offspring also may influence their decision, as 50% of the offspring will be a carrier. Other factors that may play a role include how old they are, whether or not they're single or married, and how big of a family they ultimately desire. So when it comes to options for BRCA carriers, for someone who is single or is not in a committed relationship and is considering a risk-reducing BSO in the near future, prior to either starting or completing a family, they have the option of freezing eggs. And once again, they could still carry a pregnancy when they have the ovaries removed. For someone who's single who has evidence of diminished ovarian reserve, they also have the option of freezing eggs. And in the future, these eggs could be thawed, so unfrozen, fertilized, and then can also undergo biopsy and PGD to determine if those embryos carry the genetic mutation, if that's what they're interested in doing. For married couples or women who are in a committed relationship and are considering a risk-reducing BSO in the near future, prior to either starting or completing a family, they have the option of freezing embryos. Or for a married woman who is young and has evidence of diminished ovarian reserve, she too has the option to freeze her embryos. And once again, these couples have the option of doing PGD if they are interested. For women who are not ready necessarily to freeze eggs or embryos, but still want to be proactive, one option we could do is we can monitor the ovarian reserve annually, given the possible increased risk of diminished ovarian reserve. And we could do this by doing a blood test, checking the AMH level, as well as doing a transvaginal ultrasound of the ovary, looking at the follicle count. And if they have any evidence of decline of these markers, they could choose to be proactive at the time and consider certain fertility preservation treatments. It's also important to note that there is the option of no fertility-related treatment or monitoring for these women. So what does an IVF or egg-free cycle involve? So the first step of these cycles is that the women take hormone stimulation injections, and these are tiny shots given in the lower belly, and our nurses teach our patients how to do it, or they could take an online class, and they take these hormone injections daily, which cause multiple follicles in the ovary to grow, and we monitor the response every few days with early morning blood work and ultrasounds. And these are quick visits. We get our patients in and out of the office. And they're on the shots for about 8 to 12 days until the ovaries are ready. And then they take what's called a trigger shot, and then they undergo what's called the egg retrieval 36 hours later. And the egg retrieval is done in the IVF lab. We have an anesthesiologist, and our patients receive IV sedation. And while they're sleeping, using a vaginal ultrasound attached to a needle guide, vaginally punctures the ovaries into follicles, and we aspirate the eggs, so we suck out the eggs. And the egg retrieval is a minimally invasive procedure that normally takes less than 15 minutes to complete. We'll then recover patients in the recovery room for about 30 to 60 minutes, and they usually go home feeling a little sore, a little crampy. And women who work generally go back to work the next day feeling a little sore and a little bloated. Women freezing eggs will freeze the majority of the eggs on the day of the retrieval. If they're immature eggs, we'll mature them in a dish overnight and freeze them the following day. For women creating embryos, we then combine the sperm and eggs in dish, and then we culture the embryos out. And here's a video of what an egg retrieval procedure looks like. So here you see the needle piercing the follicle and sucking out the fluid. And basically, the needle goes into, we go from follicle to follicle, aspirating the fluid, which contains the egg. And the fluid is then handed off to the embryologist to see if an egg is present. So for women and couples creating embryos, many times we do a procedure called ICSI, which stands for intracytoplasmic sperm injection, when you inject one sperm directly into the egg. And we do ICSI in cases where we're using frozen eggs, when we unfreeze them to help fertilize them, or any time that we're going to biopsy and screen the embryo and do PGD. And here's a video of an ICSI procedure. So here you see motile sperm, and then the embryologist uses a suction needle to aspirate one of the motile sperm. And then in a moment, you'll see it being injected into the embryo. And then we culture the embryos out to what we call the blastocyst stage, which is a day 5 to day 7 embryo. And that embryo can then either be biopsied and then frozen, or can also be frozen at that stage. So here you see a mature egg under the microscope, and the embryologist uses an instrument to stabilize the egg. And then the needle containing the single sperm is carefully introduced into the egg, and then they release the sperm. And then they check the following day to see if fertilization occurred. So here we see the needle being about to pierce the egg, and it's done at a specific angle. And if you watch closely, you'll see the single sperm released in the egg. If the sperm is released, the needle is withdrawn, and then the embryologist checks the following day to see if fertilization occurred. So in the future, when women are ready to undergo what's called an embryo transfer procedure, when we're going to transfer back the embryo, in order to prepare for that, we have them take some estrogen to get the lining ready. When the lining's ready, we then add progesterone, and then schedule them for the embryo transfer procedure. And the embryo transfer procedure is also done in the IVF lab. It's done while they're awake. We have our patients have a full bladder, and using an ultrasound on the abdomen, so we use an ultrasound abdominally to help guide the procedure. We then place the speculum, and then a small catheter is then placed through the cervix, and the embryo is released near the top of the uterus under ultrasound guidance. And this procedure usually does not involve any sedation and takes only a few minutes to complete. And here's a video of what the embryo transfer looks like. So here we see, I don't know if you can see my pointer, here you see the bladder, here's the uterus, and here's the lining, okay? And if you watch carefully, you'll see a catheter being advanced through the cervix into the uterus, and then the fluid containing the embryo will be released near the top of the uterus and almost looks like a splash of fluid, as you just saw. And then the catheter is carefully withdrawn. And once again, this procedure actually only takes a few minutes. So in terms of egg freezing, in the beginning, it really did not work that well. And the reason it didn't work that well was the old way we used to freeze eggs was a process called slow freezing. When we'd go to unfreeze the eggs, so thaw the eggs, a lot of the eggs wouldn't survive the thaw, and it resulted in not the best fertilization rates, embryo development rates, and subsequent pregnancy rates. Over the course of time, we changed the way we freeze the eggs to the same way we freeze embryos, which is a process called vitrification, which is a rapid way of freezing eggs and embryos, and that has revolutionized egg freezing. So with vitrification, this now, we have multiple studies demonstrating superior results with excellent survival rates following the thawing, fertilization rates, embryo development rate, and subsequent pregnancy rates. And studies show that using vitrified eggs, the success rate is comparable to that of using fresh eggs. And what I usually tell patients is the chance of getting pregnant using frozen eggs is similar to what we call age-matched fertility. So what does that mean? So someone who's freezing their eggs, say, at age 38, the chance of conceiving is similar to someone who's 38 who has infertility who is undergoing IVF. And usually what I'll tell patients is that embryos do slightly better than eggs, but now the difference is so minimal. Embryos now only have slightly higher pregnancy rates compared to the past where the difference was great. Now the difference is so minimal. So because of this, in 2012, ASRM, which once again is American Society of Reproductive Medicine, so the infertility governing body agency in the United States, they revised their committee on egg freezing and basically stated it's no longer experimental because we had good evidence demonstrating fertilization and pregnancy rates that were similar to doing fresh IVF and ICSI, and they also demonstrated that it was safe. And the studies show that there's no increase in chromosome abnormalities, birth defects, or developmental deficits in the offspring from egg freezing. So a common question we get is, how many eggs does one need? And the best way of answering this question is based on the age of the patient. And it's also important to remember that one egg does not necessarily equal one baby. So the ideal number varies based on the patient's age, but also how big a family they ultimately want. And in general, a good rule of thumb is a goal of about 10 to 20 mature eggs. But the older one is, the more eggs you typically want. And there was a study published a few years ago at the annual ASRM conference looking at the number of mature eggs needed to achieve a single live birth. And what they found was for women under 35, they need about 8 mature eggs, 35 to 37, about 10 mature eggs, and 38 to 40, about 14 mature eggs. Once again, this is an average. And the one thing this doesn't take into account is, anyone who's planning to do PGD, so to biopsy the embryo, prevent transmitting the gene, you almost need double the number of eggs because some of those resulting embryos will contain the genetic mutation, which some may not want to pass on. So that doesn't apply to anyone who's planning to do PGD. You almost need double the amount. So what is PGD? Well, PGD, or Preimplantation genetic diagnosis, is a diagnosis of a genetic condition prior to achieving a pregnancy. And this identifies embryos that are predicted to be affected with the genetic disease and those that are not, therefore allowing couples to prevent a pregnancy with a specific genetic condition. And PGD is the only way to determine whether an embryo is predicted to be affected with the genetic condition prior to achieving a pregnancy. And women who are doing a PGD cycle, they need to create what's called a DNA probe for the specific genetic mutation. So it's a linkage marker to the embryo. And in order to do this, they need blood or a swab of cells from the cheek from the patient, but also the partner. And sometimes they even ask for some family members. And it takes about 1 to 2 months to create the specific probe. And an IVF cycle involving PGD includes the process of fertilizing the egg, culture the embryo to the blastocyst stage, biopsy the embryo freezing by vitrification, and then DNA analysis to determine if the embryo carries mutation for the specific disease, such as the BRCA mutation, but it can be done for almost any genetic mutation as well as almost any identified cancer genetic mutation. So aneuploid screening allows for the assessment of chromosomal abnormalities in the embryo, things like Down syndrome. And aneuploidy, which is a chromosomally abnormal embryo, is a leading cause of implantation failure and miscarriages in an IVF cycle using unscreened embryos, so embryos that are not biopsied. And aneuploidy increases with increasing maternal age and is why older women have lower pregnancy rates and higher miscarriage rates in general. And in almost all PGD cycles, embryos also undergo this aneuploidy screening. And this process allows the identification of the single healthiest embryo that's BRCA negative and chromosomally normal or euploid. And these embryos can be later thawed and transferred in a subsequent frozen embryo transfer cycle, often referred to as an FET. And excess euploid and BRCA negative embryos can be saved for future attempts at pregnancy since these embryos can remain frozen indefinitely. They do not age. So here's what a biopsy of an embryo actually looks like. So here's a blastocyst stage embryo, a day 5 to 7 embryo, and the embryologist uses a suction catheter to aspirate some of the outside cells. And those are cells destined to become the placenta, so remove those cells is not harmful to the embryo. And using a pulse laser beam, a few of these cells are then transected. And then, after they're transected, the embryo is frozen. And the cells that were removed are sent to a specialized genetics laboratory to be analyzed. And it takes about 1 to 2 weeks to get the results of the biopsy, depending on depending on which lab it's sent to. So there was a study published about 8 to 9 years ago that was based on a focus group that took place at the 2009 National Forest Conference. And the purpose of this study was to assess the informational needs of a BRCA mutation carrier regarding issues of fertility and preimplantation genetic diagnosis options. And the results of the study highlighted the important psychosocial concerns and informational needs within this patient population. And they explored the informational needs of women who are BRCA carriers regarding issues of reproduction and views on PGD. And participants believe that information about fertility option and PGD was not well discussed by healthcare providers at the time. And some of the findings and conclusions from the focus group included feelings of guilt about transmitting the mutation to the future children. They also found a limited quantity of information about fertility options at the time and thought it was very disappointing in that regard. Most felt a sense of responsibility to take advantage of PGD, but thought a lack of information about the process and procedures existed. And the majority agreed that even if IVF with PGD was not pursued, there was an implied responsibility to at least consider the option. Interestingly, not a lot has changed over the last few years, and I based this statement on some recent abstracts that were also presented at the annual ASRM conference. For example, one study concluded that a targeted referral for fertility preservation consultation, a time of BRCA screening, may help women improve knowledge and allow improved decision-making about reproductive options. Another study found that BRCA carriers desire and would benefit from reproductive counseling after being informed of their carrier status. So despite our understanding of the medical implications of a BRCA mutation, there's still limited data on how knowledge of carrier status influences decisions about reproduction and parenthood. And BRCA carriers may benefit from reproductive counseling after being informed of the carrier status, and therefore improve their knowledge and allow improved decision-making about one's reproductive options. So I know we've been talking about various fertility treatments for BRCA carriers, but one important to ask, is it safe? And in general, information for a woman at increased risk of developing ovarian cancer due to BRCA is limited when it comes to fertility treatment. But evidence to date has suggested that fertility medication does not increase risk of ovarian cancer among women with a BRCA mutation. And similar studies have reported no harmful effect of fertility medication on BRCA-associated breast cancer. So, the studies to date demonstrate that it's safe. There was a study published within the past 2 years that also looked at long-term safety in these patients, and they found that ovarian stimulation with the concurrent use of what we call an aromatase inhibitor, which is called letrozole, which is a medication to keep the estradiol levels low during treatment, provide not only a safe fertility preservation option for women who have breast cancer, which we use letrozole all the time when we stimulate them, but also in BRCA carriers. So when it comes to options for BRCA carriers, a lot of it depends whether or not they plan to do PGD either at present time or at some time in the future. So whether or not they're going to do PGD, prevent passing on the mutation to the offspring, because that dictates what a lot of their options are. So for women who want to do PGD at some point, and if they have evidence of diminished ovarian reserve and are single, they have the option of freezing eggs. For women who are planning to do PGD at some point, who have diminished ovarian reserve and are married, they have the option of doing IVF, PGD, and banking embryos, so trying to create enough embryos to build the future family they ultimately want. So for women who plan to do PGD at some point, and if they have normal ovarian reserve and are single, once again they have the option to freeze their eggs. If they're young, say under the age of 35, and are not ready to freeze their eggs, but still want to be proactive, we can monitor the ovarian reserve annually, and if there's any evidence of decline, they could choose to freeze eggs at that point. For married women who have normal ovarian reserve and are planning to do PGD, once again they have the option of doing IVF, PGD, and banking embryos, so to try and create enough embryos to build the future family they ultimately want. Or for these married women with normal ovarian reserve and are young and say under the age of 35 and who are not ready yet to do IVF and PGD, we can monitor the ovarian reserve, and if there's any decline, they could choose to do IVF and PGD and bank embryos at that point. There's less of a role in monitoring ovarian reserve in women over 35 for a few reasons. Number one, women who are older, over 35, the chance of success with these treatments goes down, so it makes more sense if they plan to do PGD to do it when they're younger. So less of a role in monitoring ovarian reserve in women who are a little bit older. Also, many of these women may choose a risk-reducing removal of the fallopian tubes and ovaries over the age of 35. So once again, less of a role of monitoring ovarian reserve for those women. For women who are not interested in doing PGD, their options are slightly different. So if they have diminished ovarian reserve in a single, they still have the option of freezing their eggs. Or if they're young, say under 35, and not ready to freeze eggs, they have the option of monitoring the ovarian reserve, and if there's a further decline, they could choose to freeze the eggs at that point. For married couples who have diminished ovarian reserve and are not interested in PGD, they still have the option to do IVF and bank embryos without doing PGD. So it's trying to create enough embryos to build the future family they want. Or if they're not ready to try and get pregnant on their own and don't want to do IVF yet, but still want to be proactive and are young, say under 35, we can monitor the ovarian reserve, and if there's any further decline, they could either choose to try and get pregnant on their own or do IVF without PGD and bank embryos. For women with normal ovarian reserve who are not interested in PGD, similar options. If they're single, they can freeze eggs. If they're not ready to freeze eggs and are young, say under 35, we can monitor ovarian reserve, and if there's any decline, they could choose to freeze eggs. For married couples with normal ovarian reserve, once again, they could still do IVF without PGD and bank embryos. Or if they're not ready to try and get pregnant on their own, or bank embryos with IVF, we can monitor the ovarian reserve if they're young and under 35. If there's any decline in ovarian reserve, they could choose to try and get pregnant on their own, or still do IVF and bank embryos, once again without PGD. So once again, there's less of a role of monitoring ovarian reserve in women over 35 due to the effect of age on the success of these treatments, as well as some of these women may choose a risk-reducing surgery to remove the fallopian tube and ovaries. So a few other take-home points that I want to bring home here. So for any woman who knows that they want to do PGD at some point in their life to prevent passing on the gene to the offspring, I really encourage them to do these treatments when they're very young. Because when they're young, they're more likely to get more eggs, and they're more likely to get more eggs that are likely to result in a chromosomally normal embryo. Because you have to remember, a chromosomally normal embryo, 50% of them are going to be affected with the genetic mutation. So you're going to eliminate half of chromosomally normal embryos. And you're more likely to get a larger number of chromosomally normal embryos when you're young. So I can't emphasize enough the effect of age. The other thing that I want to point out is that any women who are considering, freezing eggs, freezing embryos, doing PGD, I really encourage them to do these at top IVF programs. And the reason I say that is all IVF programs are not created equally. The success of IVF programs is all based on the IVF lab. Lab is what determines the success rates. And unlike a couple who does IVF for infertility and doesn't get pregnant, they have the option of going to another program and trying again. They have a second chance. In women, in these women, they might not have a second chance because they may have taken out the ovaries and tubes. They may have done a risk-reducing surgery, so they may not be able to be stimulated again. They don't necessarily have a second chance to try again. Or they may have done these treatments when they're young and coming back at a much older age to try, and therefore the success rates are going to be lower. So I really encourage women who are considering doing these fertility preservation treatments to go to one of the top programs locally who does a high volume of egg freezing, a high volume of IVF, especially a high volume of IVF that involves biopsying the embryo. So I thought it would be interesting to run through some real-life clinical situations. So here we have a 30-year-old BRCA carrier who's single, and in the future she would like to prevent passing on the mutation. What can she do now? So she can freeze her eggs now, and in the future she can thaw out the eggs, fertilize them, and then undergo PGD. Here we have a 33-year-old BRCA carrier who is married. She would like to have 2 kids in the future, but they're not ready to start the family now and want to wait maybe 2 more years. They'd also like to prevent passing on the mutation. What can they do? So the couple can freeze the embryos after undergoing PGD, and when the couple is ready to start the family, they can then undergo a frozen embryo transfer of a single embryo that's unaffected and chromosomally normal. Here we have a 39-year-old recently diagnosed BRCA carrier who is single and plans to undergo a risk-reducing BSO in the near future. She would also like to have kids in the future. What are her options? So she can freeze her eggs now prior to the risk-reducing BSO. Here we have a 37-year-old recently diagnosed BRCA carrier who just got married. She would like to undergo a risk-reducing BSO soon, but ideally would like to have 2 kids. What can she do? So the couple can freeze the embryos now prior to the risk-reducing BSO and also have the option of undergoing PGD if they're interested. When the couple is ready to start a family, they can then undergo a frozen embryo transfer cycle. So to summarize, despite our understanding of the medical implications of a BRCA mutation, there's still limited data on how knowledge of carrier status influences decisions about reproduction and parenthood. And women at risk for development of cancer need healthcare professionals to discuss not only the medical implications of the carrier status or risk-reducing options, but also information regarding fertility preservation and PGD. And BRCA carriers may benefit from reproductive counseling after being informed of the carrier status, and therefore improve their knowledge and allow improved decision-making about one's reproductive options. And it's also important to remember that there's no one-size-fits-all treatment option that exists. So I'd like to thank you for the opportunity for allowing me to talk and open the floor to any questions. Thank you.
Thank you so much, Dr. Lederman. That was really informative. We're going to open up the floor now for any questions that our attendees have. And as a reminder, please ask your questions using the chat box. It's like a bubble at the top of your screen. And we're going to answer as many as we can. We have a few more minutes left. When you click the chat box, make sure you just type right in there and then select T.E.A.L, and we'll receive that right away. So we did get a couple so far, so we're going to kick it off with, we actually get this question fairly frequently. Dr. Lederman, do you know of any programs that would be for low income or special sort of foundation type of programs to freeze eggs?
So just, what our program does is for any patients who has a BRCA mutation, a Lynch syndrome, any cancer predisposition syndrome, they're able to get a discounted rate for freezing eggs, freezing embryos. Just like when a patient comes to see us and they have, say, breast cancer, and we're going to freeze eggs or embryos, they get a discount. We're able to get them at the same discounted rate. And we also partner with the Livestrong Foundation, which actually could help, just like cancer patients, they could also help BRCA or Lynch syndrome patients sometimes get very discounted medications and sometimes even free medications. And they base it, it's like a sliding scale. So some women are able to get discounted medications through Livestrong, and then they're also able to get a discounted rate, just like any patients we're assisting who has an active cancer.
Okay. The next question we have is, can PZG and aneuploid screening be done in pregnant women?
So, in a pregnant woman, it's too late. PGD is done before, on an embryo before you put it back. When someone's pregnant, you could do what's called a CVS or amniocentesis. So CVS is an early version of amniocentesis where you take some cells from the pregnancy to see if it's chromosomally normal, okay, and also it can be done for BRCA or Lynch or any mutation, but then it's too late. For someone, for example, who's, we see patients who have other genetic disorders who we're screening for, say, cystic fibrosis. So, when you have 2 cystic fibrosis carriers, they have a 25% chance of having a child with cystic fibrosis. And they could also have the option of doing PGD, prevent putting back an embryo that's affected. Or if they're pregnant, they could still check the chromosomes and do aneuploidy screening and see if it has the cystic fibrosis disease. And then if it's affected, they do have the option to terminate the pregnancy if it's early in the pregnancy. But the benefit of PGD is doing it before you're pregnant, so you could prevent certain situations.
Okay. If someone had ovarian cancer and now has just one ovary, what sort of options should they consider?
Well, there's different forms of ovarian cancer, and some, for example, maybe it was a low malignant potential cancer, or it's a borderline tumor, and therefore, some don't necessarily require, necessarily chemotherapy in those situations. But because they have one ovary and there's a high chance of recurrence, it may, and depending on the situation, it may make sense to consider freezing eggs or embryos in those situations, as long as their oncologist is on board, because there's a chance of it recurring in the future. And also, they only have one ovary, so the ovarian reserve, the quality and quantity, is going to be affected.
Okay. And we have one more question. If anybody else has questions, just don't forget to click the chat box, and we'll be listening in for that. But last question, is IVF and egg freezing usually typically covered by insurance?
So some insurances will cover it, for infertility, and some insurance will cover it in certain situations for a genetic disorder. So some insurances will cover IVF with PGD, even if they don't have infertility, but have a specific genetic disorder that they're trying to prevent passing on. So it all depends on the the insurance they have, but also their insurance plan.
Okay. I think that's it for questions. So thank you, Dr. Lederman. Really appreciate it. And we wanted to just remind everybody that we do have some more workshops coming up. We have a full workshop calendar. We have just a couple more minutes left. I'll continue just making a few more announcements in case someone has a question. But you can see that we do have an ovarian cancer support group. We have programs for men, for daughters. We even have some fitness workshops coming up, as well as webinars in the future. So check back on our calendar. We also have a really amazing gala coming up at the Brooklyn Museum. Our walks all across the country have been launching. So our Brooklyn one is up and running. Our Savannah, the upstate New York one is just launched. And we're doing our Ovarian Cancer Awareness Night at Citi Field that's coming up in June as well. And then this is also found on our website, but just different ways you can get involved. There's many different programs and resources that we have if anybody was interested. And lastly, there is going to be a survey that's coming up after this webinar. You guys are all going to receive an email. We just want to keep improving our webinar, so please give us feedback and let us know how everything went tonight for you, any suggestions, and if you have any additional questions. So thank you again for participating. I think that's all we have time for tonight. That concludes our webinar. Again, thank you, Dr. Lederman. And we ask that everyone fill out that brief survey and have a wonderful evening. Thank you, everybody.